later on if I ask you questions. So put yourself in a position where you can see. So it's sternoclavicular joints because those are the medial heads of the clavicle. The medial heads of both clavicles meet here. So that's where your shoulder joints actually start. If you follow them out, you reach these joints, which are your acromioclavicular joints. Which means if there's a clavicle, there's actually a acromion, right? The acromion comes from which bone? Scapula. Very good. And if you go right underneath here and press a little bit, you're going to feel a little prominence. The coracoid process. Excellent. And if you follow it, you come back up down to the acromion, you come to the back, you meet this lovely bone coming across here. That's easy to follow. The spine of the scapula. Yeah? So that is basically the things that you have to palpate. You could go down the spine of the scapula, that will be the medial border of the scapula there, and come back up, and you basically palpate all the bones. Sure, you know humeral joints? It's kind of deep, hard to feel. Really skinny person with poor musculature, you'll probably feel the humeral head. What you can do is ask the patient to extend the elbow like that, or extend the shoulder, sorry, and you'll be able to feel here. And if you run your hand across here, you'll actually feel the biceps tendon. They're running. Where is your bicep? The long head of biceps run. It attaches to the supranuclear tubercle, very good. And it runs in the intertubercular groove, which is where you're going to feel it here on the humeral head. So this is the humeral head, and the humeral head rotates with the glenoid. Yeah? So those are your joints of the shoulder. And there's one large one, the scapulothoracic joint, which is this huge joint where the scapula rotates with the back. Right? So we're understanding that when we have to palpate, we're going to palpate from the front all the way to the side, looking at the patient to make sure if they have pain or not. Come all the way to the back, and you're looking for symmetry as well, not just tenderness. Come down, all the way back up to the acromion, to palpate the coracoid process at that point in time. Make sure that you don't have any issues there. And then you could or could not palpate the humeral head. I would say no. It's a deep joint, don't bother about it. Once you palpate those things, you're fine. You'll get most of the things that you need to get. Right? So that's with respect to palpation. I completely forget to look at that. So with respect to looking, your eyes are designed to find symmetry, which is why every exam you do, they say inspection from the foot of the bed. Why do you think you do that? So the way to go smell the patient's toes? Not really. Because when you stand at the middle, between the patient's toes and you look up, everything should be symmetrical on the outside. So when you look from here and looking straight ahead, you have a good idea of the bones, the bulk of the muscle on both sides. And the shoulder is a three-dimensional joint, just like every other joint in your body. But we just went through how complex the shoulder really is. It's not just glenohumeral, right? So you have to look from the front, from the side, and from the back. You must. Even if it means you just come across and you look, that's fine. But if you inspect or look from here, and you just comment on everything and you're done, well, you get 1 mark, you get half, because you do it halfway. You could do this as well, just me. And look in the axilla. You want to see if there are any scars. So symmetry is what you have to keep in mind. But the things you're looking for specifically will be scars, atrophy, fasciculations. What else? Anything else? Masses, swellings, changes in color, anything along those lines. But the first step is what's really important to me. You must look at scarring, wasting, and what's the other thing I say? Fasciculations. Kind of important. Those 3. They comment on anything else that you see. Yeah? And that is inspect. So all 3 sides, we talk about feel already, we went through all the different ones. Movement is kind of important with the shoulder joint, because the shoulder joint is actually designed for mobility. Remember your upper limb and your lower limb. When you start as that little tumor and it's growing in the mummies, you actually start off with 4 limbs that look almost the same, but they rotate in different directions, which is why in anatomical position, the cubital fossa is in front, but the popliteal fossa is in the back. Yeah? Which means that anatomically they are very similar. They're just modified for function. The shoulder and the hip are very good examples. The shoulder sacrifices stability for mobility, which is why I can do all this. The hip sacrifices mobility for stability. which is why if you dislocate your hip, you will have a very bad injury. And like the shoulder, you go, yeah, that diamond does all the time. A hip dislocation is an emergency. Any dislocation is an emergency. But a hip dislocation, everybody's panic. And for good reason. The amount of energy it takes to dislocate a hip is tremendous. It usually happens accidents and high falls. Yeah? So, with respect to movement of the shoulder, the first thing to do is a screening exam. Screening test just gives you an idea if something is wrong. So we're going to use the Apley scratch test. How is that done? Quite simple. It takes all the movements of the shoulders, the flexion, your extension, your abduction, your adduction, your internal rotation, external rotation, and jams them all together in one big movement that you have to reverse and do on both sides. So we're going to ask Anthony, quite simply, to just do this for me, please. So what he's doing, the two shoulders doing two different sets of movement at the same time. There's adduction, abduction, internal rotation, external rotation, extension, flexion. So it combines the movement. What we can do, this is obviously normal. Yeah, no problems there. So hands down now. We need to be able to measure this objectively. Because you can document and say, Apley scratch test, normal. That don't mean anything to me really. If you want to say, well, there may be asymmetry between the limbs, then we need to have an objective. We are documenting it. Tilt your head forward. Bend forward. What's this? C7. What is C7? C7 have plenty parts. Spinal process of C7 specific, right? And it's called the vertebral prominence because it's the most prominent, right? So the vertebra, right? And it's simple. So from there, you could actually palpate. So that's C7, T1, T2, T3. And you go down. So you can now document where each finger reaches with the Apley scratch test, which spinous level. So now switch your hands to me, the left one, the left. Was that way just now?
Yeah.
Okay. But he's symmetrical, so it's not a problem. But if there was asymmetry and there is one limb that moving less than the next, you now know, hey, my pathology is there. Let me focus there. So you know where to shift your focus. So this is a quick screening test. It doesn't really give you a diagnosis. It tells you where to focus. Good. So that's the Apley's scratch test. So that's look, feel. Now we need to go through the major muscle groups of the shoulder joint. At the same time, you must check for the power in it. So you're going to look and see where the problem is. So we're going to look at the general movements of the muscle around the shoulder. Which muscles are we going to focus on? There are three main groups, or there's three muscles, well, there are groups that we need to look at. If we go from outside in, the one that you see first is this one.
Deltoid.
Deltoid. Why is it called deltoid?
3 parts.
Shaped like a? Like Greek letter delta. Right? So oid means resembling. So you have the deltoid. Yeah? Remember, you have rhomboids because it looks like a rhombus. You have the lambdoid suture because it looks like the Greek letter lambda. Things easy to remember, you know, let's have to fit the words together. So the deltoid is this huge expansor muscle that covers up the big shoulder joint superficially. It has how many heads? It has how many heads? It has how many heads?
3.
Good. So the 3 heads, anterior, lateral, and posterior. Yeah? They obviously would do different things. I mean, why would you have, if not, right? So what do they do? Let's test them. So turn and face towards them now. So what we're going to do is quickly test the 3 different heads. So what we do, ask the patient to do what I do. So I'm going to left hand straight ahead of you. Hold it here, don't let me press it down. So I'm going to come here, press here. But when you're testing for power in a muscle, it's not just about testing to see the patient can resist, it's to see the muscle actually working. We're testing anterior head of deltoid. So when I press here, I must palpate here and see if it's working. And notice where I'm pressing. I'm not pressing here or here. Because here, I'm testing forearms and biceps. Here, I'm testing biceps. Here, I'm testing anterior deltoid. Yeah? So do not skip joints. Go right up to the place you want to test. Like this to me now. Don't let me press it down. Same thing, I'm going to press and palpate. Lateral deltoid. So the hand goes back. Posterior head. One part of the example. Flexion, abduction, extension. All 3 heads are deltoid, finish. Next muscle, A lot of people don't associate it with the shoulder, but it is quite important. Which muscle are talking about? You can test traps quite easy. I'm going to press on the shoulder. That's trapezius. You can palpate it right. Right? Which nerve supplies trapezius? What are muscle that supplies? So the accessory nerve for me is always the I don't know muscle. Is the I don't know nerves. Because what does it supply? These two muscles. I'm on pass the exam for that, by the way. He was borderline passing in muscle bones and joints, and they asked him, show me the action, how you would test for the accessory nerve, and he goes, and how you remember, both of them actually embryologically come from the same bulk of muscle and they split. So sternocleidomastoid splits, so the back here is a posterior triangle of your neck. They reveal that, and both of them come from the same embryological origin. Cooler, so same nervous supply. Now, sure, so that's that. If you want to, we could be a little technical too. I want you to put your shoulder together like that. And we test rhomboids. That's rhomboids. Dorsal scapular nerve. Accessory, dorsal scapula. Right? Turn back. The pretty muscle that everybody like to work in the gym. All the boys like to work in the gym. The pectoralis, sure. We can work that. How do we test pectoralis? Kind of difficult to test here. Relax now. So the pecs come from here. This pectoralis major. They do what? What's the exercise we do for pecs? Push-ups, flies. So what we're looking at is flexion, adduction, and rotation. What? Internal rotation. So it does that. So that's why everybody, when they're doing flies, will come up like that. Or they'll focus like that. So that's the 3 movements I get for pectoralis. And that's how you can test it. If you're going to test that, test 1 out of the 3. Try not to mix movements. It confuses things quickly. But for your exam, don't worry. I wanted to test trapezius. You don't need to test rhomboids. You don't need to test pecs. What's this pretty muscle here? Biceps. Why is it called biceps? 2 heads. Where do 2 heads come from? Long head we said already. Supinate tubercle. Short head comes from the coracoid process. What are the 2 muscles attached there? MCQ. Coracobrachialis. What was on my life, boy? That's an MCQ. I just give all the MCQ answer. Yeah. I don't tell anybody to do that. Right. So that's important. The coracoid process gives rise to the following muscles, or gives rise to all the following muscles except. And you'll see those 3 muscles listed and they must know that. Yeah? So we must test biceps. What does biceps do? So when it's talking about the movement, talk about the joint. So it flexes the elbow joint. Good. What else does it do? Remember, once a muscle crosses a joint, it can move it.
It supinates.
Very good. So it's the most powerful supinator of the forearm or of the elbow joint. Now, what we need to understand is how to test for it. Because supination and pronation, it happens here, but we're actually working on the shoulder. It doesn't matter. Both heads count. Once both heads are involved, you're going to get problems with it. So what we're going to do, ask him to stand like this. We're going to keep the elbow joint at 90 degrees. We're going to teach him, and I want you to watch this. I don't want you to talk to the patient like a doctor. This is up, this is down. But we know this is supination, this is pronation. And we know biceps supinates. So I'm going to put him here and ask him to turn his hand up for me. Turn your hand up. And while I'm resisting him, I'm going to palpate here and see if he has any tenderness around the long hand of biceps. So I'm now testing the bicep muscle, which I can palpate also. And I know that it works. Yeah? Strongest flexor of the elbow joint is what muscle? Strongest flexor of the elbow joint. Flexor. By which one? No, not the bicep. Brachialis. Brachialis actually gives you 80% of your power for flexion. So while everybody likes to work on biceps brachialis. Why is it called biceps brachialis? Because you have a biceps femoris. Let's take a hint. Right? Brachialis actually gives you 80%, so that's a real power muscle and it's hidden. It's actually hidden underneath the nice pretty muscle that everybody else like to work, which is giving 20% their power, but 100% are getting sleep time. Right? So we just tested biceps. So deltoid biceps out of the way. We mentioned latissimus. We mentioned trapezius, we mentioned rhomboids, we mentioned pectoralis major. What do you know what pectoralis minor is? Do or just tell me? Tell me where it come from. I ain't getting lost in that. If I ask the patient to do this, just what do you see? Push it. Lean forward and push it. Yeah. This one? Right, push. What am I looking for?
Checking scapula, see what I'm waiting.
Go. No. Sorry, that's good. So right, that's anterior. That's right? So right, anterior does something really impressive. What it does, it holds the scapula to the back of the thoracic wall. So if it's not working, you get scapular winging. There are multiple types of winging, but you only need to know this one. Quite simple. When the patient pushes on the wall, if the serratus anterior is not working, the scapula pushes out and it becomes prominent. It looks like it's a wing. So you get scapular winging. You must test for this. And then push against the wall, look for scapular winging. What nerve supplies serratus anterior? Of who? Eponym. Long thoracic nerve of who? It's an eponym. Sorry, if I live good, I'll get better, right? The long thoracic nerve of Bell. Yeah, I'm already that sure. Right? That's serratus anterior. So we've tested all those. What are the muscles that wrap around the head of the humerus that help them with rotation? We rotate the cuff muscles. Yeah, because it forms a cuff over the head and helps rotation. Kind of simple. You see how the law of the autopods keep things simple. Right? So you rotate the cuff. What forms rotated cuff? What four muscles? Teres minor, that's kind of in the middle of everything. Subscapularis, supraspinatus, infraspinatus. Good? So, supraspinatus, infraspinatus. Why do we call them that? Because one is above the spine, one is below the spine. Kind of simple, right? And the supraspinous fossa, infraspinous fossa. That's what they are. Easy? Yes? Good. Supraspinatus is not a very smart muscle. It does important things, but not very smart. So what it does, it comes from here, but it travels under the clavicle and under the acromion, comes across that actually top of the what? Greater tuber. Yeah? So what's the problem with that? When you abduct, it gets squeezed between two bones, the head of the humerus and the acromion. But it sacrifices itself for a good reason though. Why does it sacrifice itself? Because this is the action of supraspinatus, right? But the scapula doesn't lie perfectly in the coronal plane. We know coronal, sagittal, axial, right? We know that. The trapezius refuses to stay in one plane. So it takes about 30 degrees off and it points forward. So the true movement for supraspinatus is there. About 30 degrees flexion and shifted anterior. And then it abducts, but not so far. It abducts about 15 degrees. Why does it need to do that? Deltoid is far bigger, far stronger in abduction. So why does supraspinatus need to do that? Because deltoid is at a mechanical disadvantage. Comes from here at a 90 degree angle and comes down to attach the deltoid tubercle. That 90 degrees makes a big difference. As opposed to doing this and take 15 degrees off. Now deltoid has a much better pull. The vector of pull is much better. So the first 15 degrees is supraspinatus. The next 75 degrees is lateral deltoid. And then watch this. Go straight over here to me, Anthony. High up as you can. The rest is scapulothoracic movement. Yeah? Now what I want you to look at is another thing. So 15, 75, and then the rest. Yeah? Watch something else. Go to abduction. Watch what happens here. Go all the way up. You do it now. I make you focus too much. So when he goes out, he did this. And there's a reason for that. What did he do? He rotates. Why? That's his way of getting the supraspinatus tendon out of the way for impingement. So if you're impinging, most people, when they want to do exercises, they're going to do like this and hold your weights like that. If you're impinging, just do this. You're not going to work anterior delts as much, but you're not going to impinge. You get out of the way by with external rotation, which you did there. Right? So supraspinatus, first 15 degrees of abduction, and we know why. But if you want to test it, you need to isolate. So we need to get rid of the delta a little bit. So what we do is we actually put them in a position where we can impinge this. We abduct to 90 degrees and internally rotate. But how we teach the patient to internally rotate? Thumbs up is external rotation. Thumbs down is internal rotation. It's difficult to explain to the patient this. This is much easier. So we put them thumbs down. And when he's thumbs down, now we can say, hold your hand here, let me push it down. I can push down here, and supraspinatus is working fantastically. Yeah? So we isolate it. So that's supraspinatus abduction. Hands up. What we're going to do now? What's the two muscles under the spine? Infraspinatus and teres minor. Yeah? So these 6 muscles. Supraspinatus, infraspinatus, teres minor, SIT, S is subscapularis. 6. So infraspinatus and teres minor do what? What's that movement? External rotation. So what we'll do, put the patient in neutral. And I'm going to show him, Anthony, leaving your elbows still. I want you to rotate your hands out like that. Go ahead. And he rotates out. If I want to test it, I can actually come here, keep it, and press. Feel for the muscle. Press. Feel for the muscle. So it's externally rotated. And you're testing infraspinatus and teres minor. What's the nerve supply to this? You what? We take on MBJ serious in this group. Very good. So the suprascapular nerve supplies both supraspinatus and infraspinatus. But what supplies teres minor? Dorsal scapula supplies numbers. Subscapular nerve superior and inferior supplies subscapularis. It don't make sense, right? It's the axillary nerve. Yeah. So let's say we want to test teres minor. How can we isolate teres minor? Well, we have the same way we defunction the deltoid to test supraspinatus. We're going to defunction the infraspinatus to isolate teres minor. So what we're going to do is actually take hands up like this. I want to reach up towards you all like that. So we put him in abduction and force him to externally rotate. In that position, if teres minor were weak, this would happen. And it's called the horn blower sign. Because it looks like it's going horn. Yeah? So if teres minor is weak, and he tries to touch the wall behind him, this just goes close. Teres minor is weak. But if he was able to externally rotate, if he was able to externally rotate, it means infraspinatus was working. So now you can differentiate between the two. Yeah? Last one. Subscapularis, internal rotation. How do you test that? If we know this is neutral and this is external rotation, how do you test internal rotation? Like this. Belly anyway. Yeah, mine too. So what we have to do is something a little bit different. So what we do is we ask him to put your hands on your back like this. And that's internal rotation. Yeah? But we want to test it. We don't just want to see him do the movement. We want to actually test and see if the muscle is working. Put one hand at a time. One hand at a time. One hand first. So what I'm going to do is lift your hand off your back. I want you to hold it off your back. And if you can keep it up, that means subscapularis is working. If subscapularis were weak or torn, you would have fell back like that. That's called Gerber's lift-off test. Why? Because it's lift-off. And yes, Gerber's like a baby food. Right? And you test the next hand. Next hand on your back. Want to lift it off? Keep it off for me. Gerber's lift-off test. Subscapularis. That's all. So we just tested that. Now, once you've tested all the muscle groups, which we just did, we did deltoid, we did biceps, we did the rotator cuffs, you tested trapezius, you tested serratus anterior, all those things with really simple tests that very focused on the muscle. You know what's the nerve supply, so if it's not working, you know what's the problem. Yes? Now we need to look at two of the commonest things that happen to the shoulder when you come to clinic. Because a patient with a normal shoulder not going to come to the ortho clinic and say that examine the shoulder. No. You're usually going to have a problem. You need to figure out what's going on. And the two commonest problems you're going to get, and I promise you this, you will get them: impingement or instability. Impingement simply means that you're getting pain with movement of the shoulder. And it usually happens because something that's not supposed to be touching or squeezing is doing just that. And the two commonest places for impingement is subacromial with your supraspinatus tendon. So you could get a supraspinatus tendinitis. And most tendons, when they come close to a bone, they're protected by a layer of fluid that's encapsulated. What's called that little thing? That little synovial membrane surrounds that joint. Yes. A bursa. Very good. So you have a bursa that lies subacromially, and the tendon lies right underneath that. So now you understand how anatomy is important now, right? So you can get a subacromial bursitis, and that would cause impingement too. Yeah? So how are we going to test for that? We just talk about it. How does the tendon normally impinge? With abduction and internal rotation. So let me do that. This guy by the name of Nia came up with his own test. So we discussed, well, we're going to do the same thing, but these tests are all passive tests. So we ask the patient if he had pain. If he said yes, when we know what we're looking, we internally rotate AD up to keep the shoulder square. And then I'm just going to do this passively. If he has pain, he will point for me where he's having the pain, and then we could try to localize whether or not it's that. There's one test that, for me, seems a little, I don't know if you want to call it stush or less barbaric, for the Hawkins-Kennedy test, but it does the exact same thing, except the elbow is flexed. So you flex remember, we flex the shoulder, we adapt the shoulder a little bit, and then we internally rotate. And we see. Yeah? Instead of a fight of groups. So if I have impingement, then I carry it to my shoulder. Right? So Hawkins-Kennedy test the same exact thing.
What was the name of the other one?
NEAS. N-E-E-R''S. Yeah, he's like godfather in shoulder. Fractures, test. I'll show you the other things that I can remember. Right? So that's the impingement test for the subacromial region. So you're talking about supraspinatus tendinitis or bursitis. The test for that. The other place that you could get an impingement or pain at least would be a acromioclavicular joint. So fellows who like to go to the gym, and the first day they go, they want to load up all the weights on the bench press and start pushing. You get something called distal clavicular, anybody know? Osteolysis. The distal clavicle actually starts to break down like arthritis. Because all the weight you push through your hand has to go through that AC joint. But remember, the clavicle is quite special. It's the only bone in your body that links the appendicular skeleton to the axial skeleton. So anything you push through here goes through there. And everybody is come on board. Pain here, boy. Where do you say? Bench press. So what you can do is you can press on the AC joint and ask them if they're getting pain. That's part of the palpation. So a simple press will tell you if they're getting pain directly there. The other thing you can do is tell them, take this hand for me if you're testing this joint and touch that shoulder. Lift the elbow up and push it across. It's called the crossover or scarf test. Yeah? And if it hurts, it will hurt right at the AC joint. Crossover or like a scarf. Scarf test. But I think scarf is somebody new. Yes, by the way. There's nothing to work for us. Right? So, those are your two impingement tests. And the last thing you test for is instability. Which direction does the shoulder dislocate most often?
Anterior.
Anterior. I don't know if some of the other groups didn't know what went on. I don't understand. Alright. Yeah, I can understand everything.
That's okay, we just had a lecture about them.
One by two. Oh, Suresh? Easy man. Right, anyway, so back to instability. So yeah, so if it dislocates anteriorly, then if you put force from the back to the front, in something that you need to know, and this is the position of apprehension. Never forget that too. Position of apprehension. Yeah? Position is basically where you are in space. Apprehension means you're not very happy about something. You don't want something to really happen. The position of apprehension for the shoulder is 90 degrees abduction, 90 degrees external rotation. What does this look like? That you're going to throw something. That's exactly what you don't want patients with anterior instability to do. So you will always tell your patients who had anterior dislocation, who have instability, don't throw things. So no javelin, don't pelt mango, and don't reach backward behind anything for you. They like to reach behind them on the shelf when they sit on a chair. That's bad. So the apprehension test, with that movement, I will continue to externally rotate and put my hand behind the humeral head and put it forward. He doesn't care. A patient with instability would care. Yeah? And if what they would do, anybody think they could do this? Come do it on me. Come on, we're wasting time. We have limited time. So this hand goes there. You're going to continue to externally rotate. This hand goes behind you, right? And pull it forward. And this is what I want. I don't want that. My children say. Right? I don't want that. So as soon as he pulls forward, I'm going to shift my body forward to compensate. If I were lying flat, he does that, I would roll towards him. That's a positive apprehension test. Right? So, you see how difficult it is? He was watching me do it and still at the end of the position, which is why I need to practice. That goes for everybody. Yeah? Looking at me doing the test is not equivalent to you being able to do it on the day of the exam. If you don't practice, learn to put your hands in the position that they need to be in. Put the pressure that you need to. On the day of the exam, you're going to fluster. You're going to be completely flustered. Yeah? So, that's the apprehension test. So if I find he is apprehensive, and I do this, and press down, and he relaxes, that's called the relocation test. And that's even more confirmatory. And you're basically done. That's the